Okay. Good morning, everyone. I am presenting a paper, Transversus Abdominis Release, our experience in managing W2 and W3 incisional hernias over the last 2 years. If we go through last 100 years of experience in repairing incisional hernias, we come to 2 or 3 major pit stops. The first is in France in 60s and 70s, where we saw Reeves and Stoppa demonstrating the retromuscular plane and putting the mesh there. Then one showed us the GPRPS, and from there the anterior component, posterior component, and lastly we come to Nowitzki, where from 2016 to 2012 he showed the TAR. In our study, we performed a prospective study for our patients coming to our unit only. There were 28 patients who had W2 and more defects. We repaired 16 with TAR. The spectrum of cases were varied, with many having loss of domain and incarceration. So we had to go for TAR in all these cases. We used CT as a tool to demonstrate the defect and classify the patients. Why did we target the transversus? We targeted because it's the muscle which is responsible for maintaining the hook tension of the body. It follows the Pascal's law, and that's the reason we release it. What are the limitations of the techniques which used to be previously applied? In the classic Reeves Stoppa, we can dissect only up to the linear seminal, and in the pre-peritoneal, as demonstrated by Hanniford, it's difficult to reproduce and it's not a reconstructive approach. And in the Carbonell method of posterior component separation, he went to the intermuscular plane between the transversus and internal oblique and denervated the recti. The neurovascular bundle was lost. So we came to this man, Yuri Nowitzki, who showed us the TAR. This is his 2012 paper. And the advantages of TAR are that it is effective in restoration of the linea alba. It gives reinforcement to the giant sac. There are no skin flaps. The neurovascular bundles are preserved. It's safe, effective, and reproducible. Our decision making was based on mainly the classification of EHS and then his comorbidities. Most patients had a BMI hovering around 30. In our procedure, we took an average time of 6 hours. Some took longer, with the average blood loss of about 330 ml. The patients are discharged on the 5th or 6th day mostly. Coming to the steps, we follow the standard steps. This is the step which I want to emphasize. After dissecting the retrorectus plane, we go through this trick. We know that the transversus of muscle overshoots the linea in the upper half, so there we peel off the posterior lamina of the internal oblique and then go to the plane between the peritoneum, transversalis fascia, and the muscle. This is our main audio video where I use the diathermy. Many people may use the scissor. Laterally we go till the swas, and superiorly we go till the central tendon, and inferiorly till the Redzius. Here we can see that we have created an adequate space and putting a mesh about 15 to 50 centimeters in most cases. We fix our mesh at the lower body near the Coopers, and this allows us to recreate the linea and help restoration of the function. We had challenges. First challenge is the access. See, this almost the entire gut is outside the abdominal wall. So additionalization was a challenge, and then putting it back is a different thing. This is the sac which we got, and we use the sac to reconstruct the posterior sheath. Here, if you don't get enough adequate closer, we may use mesh, and there are complications. 2 major complications are requirement of invasive ventilation and abdominal compartment syndrome. The most important message I will give is go for the plateau pressure and not the bladder pressure. Plateau pressure guides you in keeping the patient intubated post-op and maintaining it even after 24 hours. If the plateau pressure is more than 11, bladder pressures are misguiding in most cases. So this is our patient. The patient is happy after OT. The surgeon is also happy. Thank you. The major limitation is the time and the resources needed, and also of course the many patients may recur, but we haven't seen there are success stories. Thank you.
Some of the patients you have shown as loss of domain.
Sir.
Even if we consider TAR, that may not be enough. So how do you optimize this patient? So you decide to go for that.
So before going for trial, we generally take a lot of time in optimizing the patient. We may go for using a belt wherein we put on all the gut outside and create a space there. In some cases, we may use Botox, but in government set up Botox is a restraint. But
in your cases, in 16 cases, what are your...
in 16 cases, we had told them to use abdominal belts and put on the gut inside and then put on the belt. So some space is created inside and then we take up the patients.
And if you do TAR from central tendon to the free space, a 50 by 50 mesh is not...
Sir, 50 by 50. It is 50 by 50. Ponchas.
50 you say?
Ponchas, sir, 50 by 50. 15 will migrate, it will, it will migrate. 50 by 50 is the mesh which we apply, sir. Medium weight, macroporous, proline mesh we use.
Any incidence of post-op compartment syndrome in any of these patients?
So we had 2 patients with compartment syndrome. One of the patients had to be ventilated for a pretty long time and then the patient came out. And in other patients we had 3 days of ventilation. The I2 guys helped us a lot and they were keeping them sedated so the pressure is down and maintaining the adequate PEEP and blood pressure.
Do you have any experience of step-up pneumoperitoneum in this case, in your case?
No, sir, we haven't seen pneumoperitoneum. No.
How long did you have the drains?
So we put drains over the mesh. We put drains.
Suction drains or the just
Suction drains.
capillary drains?
Suction drains for 3 to 4 days.
3 to 4 days or till you drained?
Yes, sir. No, sir. We are routinely remove drains at 5 days because it will keep on the serous fluid will keep on coming and we are good with it.
You put the abdominal corset after the operations?
No, sir. We don't put.
Routinely?
No, sir. No, sir.
What tips you take for prevent neurovascular bundle injury?
The neurovascular bundle injury may be prevented by if we go to the plane 0.5 to 1 centimeter medial to the linear semillunaris. That's the tip.
What DVT profile exercise you take?
So we routinely follow the word and we also go 1 centimeter medial to the linear semillunaris and that helps us. Till now we didn't have any rectus atrophy. Not since, sir.
Are you proper any DVT profile access in these patients?
Yes, sir. Para post-op, we go for DVT prophylaxis. We give whatever is available in our hospital.
Pump?
Pump, yes, sir. We have pump in our room. We have pump in our room.
Okay, thank you, sir.
Thank you, sir. Sir, 2 incisions because that patient had. Okay, sir. I will show you this. Sir, this one, sir. This patient. So in this patient, the patient had a subcostal hernia. Had a huge hernia in the subcostal region. So we went through the midline and did the TAR, did whatever is necessary, and removed the scar tissue in the subcostal area, and then reconstructed.
You see, if it is subcostal hernia, it is very difficult to get your transversus plane on the side of hernia.
So there comes the role of TAR. Yes, sir. Yes, sir.
Very difficult.
Very difficult, and that's the reason, sir, we don't go pre-peritoneal in subcostal. Pre-peritoneal subcostal we can't approach. Their TAR will be of help.
Thank you, sir.
Thank you, sir.
I would now like